It's actually unmute पे है. Are you able to hear? तो तुम अनम्यूट करके बात कर लो थोड़ा. मुझे सुनाई दे रहा है कि नहीं मालूम होगा.
Hi, Chandra.
या डन. बढ़िया सुनाई दे रहा है. How many participants are there? Hello, ma'am.
Yeah, good evening. It's already,
Ma'am,
I think 11 people have joined. We'll wait for
yeah.
some more time.
Okay, ma'am.
Wait for at least 12, 5, 9, 5.
Okay. Okay. Ma'am, shall we start, ma'am?
Yeah, we shall start. I thought I was waiting even for Dr. Swapna to join. I don't know if she's
Ma'am,
got some. Did
ma'am
you?
is ma'am is busy, it seems, ma'am.
Okay,
I
okay,
just know I
fine.
can't.
Yeah, okay. So, good evening, everybody. So, we'll be starting the topic today. It's on acute liver cell failure in neonates. And since so many things are not very clear, the definitions, the management, and the diagnosis, but still, since the advances in investigations now help us to pinpoint the diagnosis better than before, and less than 5% of cases actually are idiopathic, are labeled as idiopathic in neonates. So, with the advances and the pathophysiology knowledge and management, now our outcomes have improved, but still there are so many hazy pictures and which we miss if we are not clear and don't take a proper history. So today Dr. Chandrashekar will be taking us through this tough topic, and please be attentive and you can ask questions, and I request all the participants to be muted during the presentation. So thank you, Dr. Chandrashekar. You can start.
Good evening, everyone. Myself, Dr. Chandrashekar Angadi, second year DM Neonatology Resident from Niloufer Hospital. And my moderator for today's topic is Dr. Alimelu, Professor and HOD Department of Neonatology, Niloufer Hospital, Hyderabad. And today I will be doing a seminar on acute liver failure in neonates. So today's seminar's outline will be introduction of neonatal acute liver failure, followed by definition and epidemiology, followed by various etiology and various mechanisms involved in neonatal acute liver injury, and various pathophysiology and what are the investigations and how it is to be managed. So coming to the introduction, neonatal acute liver failure is a rare and is a very less understood disease, and it is associated with very high mortality of up to 55 to 70%. And one of the most common known etiology for neonatal acute liver failure is gestational alloimmune liver disease. And as there are several causes of neonatal liver failure, early diagnosis and initiation of specific treatment is a key for management. And till today, there is lack of consensual recommendations or guidelines for management of neonatal acute liver failure. Coming to the definition, according to Pediatric Acute Liver Failure Society Group, acute liver failure in children is defined as onset of liver dysfunction in the form of elevated liver enzymes of ALT, AST, and GGT of more than 100 and bilirubin of more than 5 within 8 weeks of clinical symptoms. And there should not be underlying chronic liver disease and associated with coagulopathy, which is not corrected even after administration of parenteral vitamin K. And coagulopathy will be defined as prothrombin time of more than or equal to 15 seconds or INR of more than or equal to 1.5 with the evidence of hepatic encephalopathy, or PT of more than or equal to 20 seconds or INR of more than or equal to 2 without encephalopathy. But in neonates, like INR of up to 2 may be normally observed in a normal term neonates, or INR can be even more than or equal to 2 in normal preterm infants. For this reason, for neonatal acute liver failure, an INR cutoff of more than or equal to 3 should be considered for defining acute liver failure. And as neonatal period lasts from birth to 28 days. So, irrespective of intrauterine insult, any liver failure in the first 28 days of life should be considered as a neonatal acute liver failure. Coming to the epidemiology, neonatal acute liver failure is a very rare disorder, and although the incidence of acute liver failure is reported to be 17 per 1 lakh in all ages, the incidence in newborns and children is unknown. And an entity called gestational alloimmune liver disease, which was not even known a decade ago. Now it has been known to be the most common etiology for neonatal acute liver failure, and mortality can range from 55 to 70%. Coming to the etiologies, most common etiology being neonatal hemochromatosis, which accounts for up to 60 to 80% of the neonatal acute liver failure. And among this neonatal hemochromatosis, most common cause is gestational alloimmune liver disease, followed by infections and trisomy 21 or bile acid synthetic defects and Gracile syndrome, myofibromatosis, and trichohepatoenteric syndrome, and Martinez-Frias syndrome. And next most common cause is infections, which account for 20 to 30% of the NALF, and most common being viral etiology. Among the viral etiology, herpes simplex virus is the most commonly encountered, and followed by enterovirus and CMV. And other rare viruses include HSV6 and adenovirus and parvovirus. And few bacterial infection and fungal infections, candidal infections can also lead to neonatal acute liver failure. And few case reports of scrub typhus causing neonatal acute liver failure has been published. And next most common is common cause for neonatal liver failure includes metabolic diseases, which accounts for up to 10% of the cases, which includes galactosemia, tyrosinemia, and hereditary fructose intolerance, and various mitochondrial disorders, including fatty acid oxidation defects and respiratory chain defects, and few storage disorders like Niemann-Pick disease and glycogen storage disorders and urea cycle defects. And next common cause is hemophagocytic lymphohistiocytosis, that is HLH, which accounts for less than 10% of the cases. It can be either primary or secondary. And coming to the other rare causes like ischemic liver injury, secondary to either perinatal asphyxia or hypovolemic or cardiogenic shock, or it can be seen in right heart failure. And other rare causes include toxic injury caused by various drugs like antibiotics like isoniazid, amoxiclav, ampicillin, and sulfonamides. And few anti-seizure medications like phenobarbital and phenytoin and carbamazepine are known to cause neonatal acute liver failure. And acetaminophen, when used in excessive doses, can cause acute liver failure. Coming to the various mechanisms of liver injury involved in this acute liver failure, uh, the mechanism varies according to etiology. Like in gestational alloimmune liver disease, it is the failure of hepatic parenchymal development or the destruction due to the complement activation. And in etiologies like viral infections, hypoxic injury resulting from circulatory failure or cardiac defects, and toxic injuries and HLH, acute hepatic necrosis will be seen. And other mechanisms include replacement of hepatic parenchyma with the non-functioning tissue, as seen in massive hepatic hemangiomas, and infiltration of the liver can be seen as a mechanism in cases of malignancies like congenital leukemia, neuroblastoma, and nephroblastoma, and Down syndrome associated with myelodysplastic syndrome. And other mechanisms like failure of hepatocyte organelle function is seen in toxic liver injury, as in acetaminophen injury, and mitochondrial cytopathies. Steatosis and cholestasis is seen as a mechanism in toxic injury, galactosemias, and tyrosinemia. And coming to the pathophysiology of various etiologies, neonatal hemochromatosis being the major cause, we will discuss it first. So, NH is a term given to extrahepatic cirrhosis associated with the liver disease, and it has to be differentiated from hereditary hemochromatosis. Hereditary hemochromatosis is a autosomally recessive inherited disorder. It is caused by reduced hepcidin, which leads to the excessive enteric absorption of iron and accumulation in various organs. The treatment will be phlebotomy and using of iron chelators. And pathophysiology of NH will be discussed further. Uh, Among causes of NH, GALD, that is gestational alloimmune liver disease, is being the most common cause, and the true inheritance is unknown. It is thought to be congenital and familial, but not hereditary. And most oftenly, children will present within hours of birth, but presentation can occur even up to 3 months of age. And the incidence of GALD is rare, as reported in United States. It is reported to be 4 per 10,000 live births. Coming to the pathophysiology, initially this fetal hepatocyte antigen will be exposed to the mother, and there will be maternal production of IgG antibodies against fetal hepatocyte antigen, which crosses placenta and binds to the hepatocyte antigen, which leads to the activation of complement cascade and formation of membrane attack complex, which results in liver injury and dysfunction. There will be decreased production of hepcidin, which results in increased transport of placental iron into the fetus and excessive iron accumulation in extrahepatic tissues. But the salient feature of GALD will be there won't be acute hepatic necrosis as compared to the infective etiology of neonatal acute liver failures. And the tissues which are commonly affected by cirrhosis include pancreas, salivary glands, and mucosal glands of oropharynx and nasopharynx, and thyroid follicles, myocardium, and adrenal cortex, and respiratory airway epithelium. So this is the histopathology slides. In slide A and B, it is showing excessive iron accumulation in the hepatocytes, and in slide C, excessive iron accumulation can be seen in pancreatic acinar cells. And in slide D, there is excessive iron accumulation in thyroid follicular cells. Coming to the clinical features of gestational alloimmune liver disease, there will be often a family past maternal history of unexplained fetal death or stillbirth or a miscarriage, or a sibling who is having unknown illness or a liver disease. Findings on history and examination includes edema, high drops, and prematurity, intrauterine growth restriction, ascites, and oligohydramnios, jaundice, and coagulopathy can be seen. Coming to the diagnosis is made by documentation of extrahepatic cirrhosis by doing buccal biopsy and presence of iron accumulation in the mucosal cells, and doing an MRI abdomen to look for excessive iron accumulation in the solid organs. And usually we see either normal to mildly elevated transaminases because there is no hepatic necrosis involved. And but there will be significant elevated INR associated with hyperbilirubinemia, and alpha fetoprotein will be elevated, and transferrin saturation will be elevated, but there will be transferrin levels will be low because of decreased production, and ferritin will be elevated. Coming to the treatment, as we know, GALD is a very severe and rapidly progressive disease. There should be a low threshold to initiate specific treatment, which includes intravenous immunoglobulin at the dose of 1 gram per kg. Uh, Before even the diagnosis is confirmed. And once the diagnosis is confirmed, we have to go for double volume exchange transfusion and a second dose of IVIG at the dose of 1 gram per kg. A study by Rand EB et al. They have reported survival without transplant of up to 75 to 80% with the above mentioned approach, as compared to as compared to historical controls, which have reported 10 to 20% of survival without transplant. Coming to the prevention, uh, GALD has a recurrence risk, there is a recurrence risk in future pregnancies, which is approximately 80 to 90%. So, GALD can be prevented by giving IVIG in future pregnancies right from second trimester at 14 weeks, 1 gram per kg IVIG, and followed by at 16 weeks, 1 gram per kg IVIG, followed by weekly doses of IVIG from 18 weeks of gestation till the pregnancy is continued. And in a study by Whitington PF et al., this approach has led to a positive outcomes in terms of prevention of the GALD or decrease in severity of GALD in 99% of the cases. Coming to the next most common etiology, that is viral infections. Among viral infections, herpes simplex is the most commonly defined viral etiology. It is usually acquired during birth or postnatally by active lesions of the caretaker or the mother from lesions of the skin or the lips. And neonates can present from first week to second week of life with symptoms of poor feeding, lethargy, and encephalopathy, or skin lesions, or with seizures. And diagnosis can be made with um, PCR studies from blood or skin lesions or CSF analysis. And immediate treatment with acyclovir is a must because without treatment, there is 80% mortality with the disease. And the next most common viral etiology being enterovirus, it should be suspected whenever there is more generalized symptoms, including respiratory distress, diarrhea, and features of NEC associated with neonatal acute liver failure. And diagnosis can be made with PCR from blood, CSF, and stool analysis. And treatment is usually supportive care, and newer drugs like pleconaril can be tried. And next most common etiology being metabolic causes. Among metabolic causes, galactosemia is also known to cause neonatal acute liver failure. It is inherited as autosomal recessive disorder with a prevalence of 1 in 40,000 to 1 in 60,000 all over the world. And it is caused by a deficiency of GALT enzyme, that is galactose 1-phosphate uridyl transferase. Whenever a neonate with galactosemia is uh, breastfed or uh, uh, formula feeds containing lactose, it is metabolized into glucose and galactose. So this galactose will be metabolized by galactokinase to galactose 1-phosphate. Further, this galactose 1-phosphate will be converted to glucose by this GALT enzyme. This will be inhibited. When the enzyme is absent, this galactose 1-phosphate will accumulate in the organs like liver, kidney, and eye to cause tissue damage. So presentation can be within first few days to first few weeks of life, and it is seen only after initiation of breastfeeding. Clinical symptoms include vomiting, failure to thrive, anorexia, jaundice, hepatomegaly, features of hepatic failure associated with E. coli sepsis and cataract. Coming to the diagnosis, galactosemia can be screened through newborn screening, or urine can be screened for non-glucose reducing substances. The confirmatory test is establishing a reduced enzyme activity that can be detected in erythrocytes, liver, cultured fibroblasts, and leukocytes. Prenatal genetic testing can be done by amniocentesis and chorionecular sampling. Treatment of galactosemia is predominantly elimination of lactose and galactose from the diet. And another coming to the another cause of metabolic causes, which includes tyrosinemia type 1, that is hepatorenal type. It is inherited as an autosomal recessive disorder, and it occurs in deficiency of fumarate acetoacetate hydrolase. Clinical presentation can be acute or chronic. Most patients will present early in infancy with acute liver failure. Clinical profile includes signs of liver failure with associated with typical boiled cabbage urinary order and elevated alpha fetoprotein levels for the age. And renal features can be Fanconi syndrome, nephromegaly, hypophosphatemia, and vitamin D resistant rickets. And the neurological symptoms include autonomic dysfunction, pain, weakness, seizures, and peripheral neuropathy. And another cause of metabolic metabolic cause includes hereditary fructose intolerance. It is an autosomal recessive disorder caused by a deficiency in aldolase B enzyme, which leads to accumulation of fructose 1 phosphate, leading to tissue damage. So, this is usually seen in period of weaning when the children, older infants are fed with fruit juice containing fructose. The symptoms will be appearing. But in neonates, it can present on exposure to fructose or sucrose containing formula feeds.
Here, Dr. Chandrashekar, here
Ma'am?
uh, actually even our multivitamin drops also are actually having fructose in them. So sometimes
Oh,
when you start these multivitamin drops and the mother
oh,
complains that the child has vomiting or maybe not tolerating, we'll have to consider that because these multivitamin drops too are actually supplemented with fructose to make the taste, to
oh,
give the
okay.
baby a taste. So fructose or sucrose can be added in them. So this
Okay.
one more thing. So not only older children, even in neonates, this can happen.
Okay.
Continue.
And um, other metabolic causes for neonatal acute liver failure include mitochondrial disorders, which are again classified as disorders of fatty acid oxidation, which includes carnitine palmitoyl transferase 2 deficiency and DNA depletion syndromes. Examples include deoxyguanosine kinase deficiency and MPV7 mutations, and other respiratory chain defects like Gracile syndrome. And clinical features include all mitochondrial diseases usually present with multi-organ involvement, and lethal neonatal forms present with cardiomyopathy, arrhythmias, seizures, cystic kidney disease, and facial dysmorphism. And they present with lactic acidosis.
Yeah, here again, fatty acid oxidation defects. The mother can have a HELP-like syndrome. So the history
Okay.
again is very important. So knowing that the mother having HELP-like syndrome, HELP and the neonate presenting with the liver cell failure, kindly consider fatty acid oxidation defects.
Yes. And HLH can be one among the cause for neonatal acute liver failure in less than 10% of the cases, and it occurs due to inappropriate activation of T lymphocytes and macrophages, which results in defective apoptosis and reduced cytotoxic activity. And HLH can be either primary or secondary, and 30 to 60% of the primary HLH is associated with the mutation of the genes which encode for proteins like perforin. Uh, Monk 13.4 and Syntaxin 11. And familial HLH are universally fatal unless treated with hematopoietic stem cell transplantation. And secondary HLH, which results from either overstimulation of the immune system by the triggers like infections or immunodeficiency or in malignancies. This is the diagnostic criteria for HLH according to HLH 2004 protocol, which includes two criteria. One is molecular diagnosis consistent with the HLH or any five of the eight following features, which include fever, splenomegaly, cytopenia, and hypertriglyceridemia and or hypofibrinogenemia. Hemophagocytosis demonstration in bone marrow, ascitic fluid, liver, spleen, or lymph node biopsies, and low or absent natural killer cell activity, or ferritin, hyperferritinemia, and increased soluble CD25 antigens. Coming to the investigations, so whenever there is a biochemical evidence of liver injury in the form of elevated AST, ALT, and GGT or hyperbilirubinemia in units, we should check for coagulation. That is PT, INR, and APDT. Whenever there is prolonged PT, INR, we should suspect liver failure and we should administer injection vitamin K 1 mg and recheck clotting factors in 6 hours. If it gets normalized, it will be because of vitamin K deficiency. If it is still prolonged, then acute liver failure is confirmed. And first line of investigations include hematological investigations like complete blood picture to look for cytopenias and PTINR, APDT fibrinogen to look for coagulopathy. And biochemical tests include liver function tests to look for elevated liver enzymes and hyperbilirubinemia, and sugars to look for hypoglycemia, and serum ammonia levels to monitor for encephalopathy, and serum electrolytes to look for hypernatremia, hyponatremia, and ferritin levels as in cases of gestational alloimmune liver disease and HLH, and blood gas analysis to look for metabolic acidosis and elevated lactate in cases of mitochondrial diseases. And microbiological profile includes C-reactive protein and blood cultures. Coming to the specific investigation for targeted evaluation, whenever there is a suspicion for GALD, buccal mucosal biopsy should be done, and MRI abdomen to look for iron overload or cirrhosis in various other organs. And whenever viral etiology is suspected, specific serological tests and PCR tests of bodily fluids can be done. And in suspicion of galactosemia, GALT enzyme assay can be done, which is specific. And for tyrosinemia, urine for succinyl acetone and AFP levels which are elevated in case of tyrosinemia. And for HLH, to look for hypertriglyceridemia and elevated soluble CD25 antigen and decreased or absent natural killer cell activity can be seen. And for mitochondrial disorders, lactate and pyruvate ratio should be done. And for definitive tests like for familial HLH and mitochondrial disorders, mutation analysis has to be done. So coming to the basic differentiation of basic baseline investigations, uh, actually in GAL gestational alloimmune liver disease, transaminases are either can be either normal or mildly elevated in hundreds, whereas in other etiologies there will be moderate or very significant elevation of up to thousands or even more than thousands. And INR will be significantly elevated in gall disease, and it can be moderate to significant elevation in other conditions. And ferritin can be elevated in gestational alloimmune disease. Range It can range from 800 to 7,000 nanogram per ml. But in HLH, it can cross up to more than 20,000 units, and even in viral infections. And elevated triglyceride levels is seen only in cases of HLH, and hypoglycemia can be seen in all the conditions. Lactic acidosis is seen in either mitochondrial diseases or ischemic causes of neonatal acute liver failure. Alpha fetoprotein can be seen elevated in GALD and mitochondrial diseases and tyrosinemia. Coming to the management, it can be supportive management or specific management. In supportive management, coming to the fluid and electrolytes management, as the babies with neonatal acute liver failure are more prone for fluid overload and cerebral edema, we should target fluids of around 80 to 90% of the total daily maintenance, and we should avoid hyponatremia and extreme hypernatremia. For that, electrolyte monitoring should be done at least 12th hourly. And babies with neonatal acute liver failure are prone for hypoglycemia, so frequent glucose monitoring has to be done. And target glucose between 90 to 120 milligram per deciliter. For maintaining this, babies might require glucose infusion rates as high as 10 to 15 milligram per mg per kg per minute. And coming to the nutritional management, lactose-free formula should be initiated till the galactosemia is ruled out. And to avoid catabolism, like 0.5 to 1 gram per kg of protein has to be supplemented either parenterally or enterally. And it can be decreased based on the ammonia level. And coming to the neurological management, babies with acute liver failure are prone for encephalopathy. So, baby should be monitored for encephalopathy, and the lactulose can be given via NG or as an enema for encephalopathy because of hyperammonemia. And there should be minimal handling and avoid sedation whenever possible. And seizures has to be controlled with anti-seizure medications like phenytoin, phenobarbital, and levipil. And in cases of cerebral edema, target sodium of 145 to 150. And noradrenaline infusion can be initiated to maintain cerebral perfusion pressure. And coagulopathy can be managed by administration of vitamin K. And blood products has to be given only during invasive procedures or whenever there is active bleeding. And FFP can be given at the dose of 10 to 15 ml per kg, and cryoprecipitate in the range of 5 to 10 ml per kg. And babies has to be monitored for intracranial hemorrhage by serial cranial ultrasound. For gastrointestinal hemorrhage, we should start acid suppression. And for infections management, whenever a case of neonatal acute liver failure is identified, we should start them with acyclovir even before the HSV diagnosis has been made. And we should initiate broad spectrum antibiotics to cover gram-negative bacteria, and antifungals also to be started to cover candidal infections. Coming to the specific management, for gestational alloimmune liver disease, it is double volume exchange transfusion and administration of intravenous immunoglobulin. And in cases of herpes simplex virus, acyclovir is the drug of choice. And for cytomegalovirus infection, IV ganciclovir or oral valganciclovir can be started. For enteroviral infection, the research drug pleconaril can be used. And in cases of galactosemia, it is a galactose-free diet. And in cases of hereditary fructose intolerance, fructose-free diet has to be given. And in tyrosinemia, nitisinone is the drug of choice. And in cases of mitochondrial illness and respiratory chain defects, antioxidants, vitamins, and cofactors like carnitine, riboflavin, and coenzyme Q can be given. And in cases of HLH, chemotherapeutic drugs according to HLH 2004 protocol, which includes dexamethasone and cyclosporin and etoposide. For primary HLH, hematopoietic stem cell transplant is the definitive treatment. And those babies who do not respond to the specific and supportive management, liver transplantation is the treatment of choice. Approximately 15 to 16% of the neonates with acute liver failure will require transplantation. And the indications include galled viral infections and metabolic diseases if the neonate is not responding to that specific therapy. Contraindications include severe sepsis, and whenever there is irreversible multisystemic illness or multi-organ dysfunction, as seen in mitochondrial diseases. Due to their small size, neonates often receive a left lateral segment for orthotopic liver transplant. And as neonates lack blood group sensitization, ABO incompatible liver transplants can also be tried. And according to a study by Sundaram et al., they have noted post-transplantation, neonates will be requiring more frequent reoperations because of either graft failure or uh, there is a risk of bowel perforation and internal hemorrhages. And they have more chances of infections and prolonged hospital stays and prolonged duration of mechanical ventilation when compared to older children. And according to the same study, they have noted graft survival, which is reported to be 76%, and patient survival is reported to be at 88% post 1 year transplant. And take home messages for today's seminar. Uh, Neonatal acute liver failure is a life-threatening condition which may present with the subtle signs such as poor feeding, lethargy, and fever. Timely identification of the etiology is crucial for initiation of specific treatment, and over the time, outcomes have improved with a better understanding of the mechanism of liver injury and the treatment of gestational alloimmune liver disease. And most common known etiologies include galled viral infections and metabolic diseases and ischemia. Treat whenever IVIG, treat with IVIG whenever galled is suspected, and uh, like till the galactosemia is ruled out, eliminate lactose and galactose from the diet, and supportive care should be provided to all the cases of neonatal acute liver failure in the form of maintaining euglycemia to avoid cerebral edema and provide adequate nutrition and manage encephalopathy and control of bleeding. Specific treatment should be provided once the etiology is determined, and the liver transplant should be considered in neonates with unknown etiology or those who are not responding to the specific therapy. Thank you.
Coffee. है ना?
Any questions? No questions in the chat box either.
क्या? छोटे से बच्चे से पापा को डांटो, पापा को डांट दो।
Ma'am, shall we wait or
Coffee.
shall we end the
Yeah,
session?
I think we'll see for a few minutes. So, like as covered in the take-home message, I think as always, good history is very important. So, asking the mother's detail, maternal history will give us many clues. Yeah, I think there is one question, Dr. Chandrashekar, you can answer.
Dose of IVIG is 1 gram per kg, ma'am,
I think he
for
also
GALD.
asked about duration and how long.
GALD can present up to 3 months of age, so it can be considered up till 3 months of age.
No, he is asking the duration of IVIG, I guess. So it's how many doses he wants to
Actually,
know.
according
Yeah,
to studies, initial dose even before the diagnosis, 1 gram per kg, followed by whenever the diagnosis is established, exchange transfusion, followed by a repeat dose of IVIG at
yes.
1
So
gram per kg.
double volume exchange transfusion followed by another one, again
Another
one
dose
more.
of IVIG.
So this actually improves the outcome.
Yeah.
So any other questions? So there can also be a presentation of ascites like picture. So in a neonate, any role of N-acetylcysteine?
N-acetylcysteine is only recommended in cases of acetaminophen toxicity, ma'am.
Yes.
Otherwise, not as a routine.
Yeah, not, and that definitely not in neonatal acute liver failure. They have not recommended, not mentioned at least.
And role of albumin, they've asked, ma'am. According to literature, there is no review article has suggested for albumin, ma'am.
Yes. And I think if you see beyond neonatal age group, I think the first reason for liver transplant has been biliary atresia. But
Yeah.
within the 24 weeks, within the first 28 days, it's most of the time GALT is the commonest reason for liver transplant. And I think even in future, most hospitals will be recommending. So, yeah, sure. Dr. Chandrashekar will be sharing the PPT in the group as well. I think we keep seeing these cases. Sometimes we do not diagnose it. I guess so. Being alert and knowing when there is history of fetal losses in the mother or recurrent neonatal losses, and when you have a case with unexplained increased coagulopathy, um, without the enzymes not really rising abnormally, and unexplained IUGRs, prematurity, all these are the clues. And being alert, yes, mitochondrial diseases can cause hepatic failure. Now, Chandrashekar, one more question.
Yes, ma'am. Mitochondrial diseases like fatty acid oxidation defects and carnitine palmital transferase 2 deficiency, they can present with neonatal acute liver failure.
Yes.
Treatment is again for mitochondrial disorders, that is supplementation of cofactors like carnitine, riboflavin, and coenzyme Q. These have to be supplemented in higher doses.
And I think these cases are not usually taken up for liver transplant as well because of the other organ involvement, especially myocardial.
Cardiomyopathy.
Yeah, cardiomyopathy. Can you share the doses? Which doses?
I think that
Oh,
cofactors
that's why he's
is
asking
asking.
for the. Okay, okay.
Okay. Doses I will share in the group, ma'am,
Yes.
later.
Yeah, I think. Are we done, or do we have any more questions? So some of these viral entities also can cause these acute liver failures. So the mother's history is very important. Looking for evidences of herpes simplex, and whenever you have unexplained NALF, you can start off acyclovir after sending the investigations. So because this can be life saving in these neonates as the mortality is very high without treatment. So if we don't have any questions, shall we end the presentation? Can we end the today's session? I don't see any more.
No more questions in chat
Yeah,
box.
no more questions. Okay then. Thank you, everybody. Thank you for attending. And thank you for staying muted during the presentation. Thank you.
Thank you,
Thank you.
everyone.
Yeah, good night.
Yeah, ma'am, good
Good
night.
presentation, Dr. Chandrashekar. I
Thank you,
think
ma'am.
you were very clear.
Oh.
Right. Thank you. Bye.